I wanted to bring today's episode to the podcast talking about what we wish we can ask an embryologist. Going through IVF can have a whole lot of different stressors associated with this and a lot of unknown. So today we are breaking down some of the top questions that an embryologist would be asked. So you can really, if you decided that IVF is your option, you can face this with a little more information in your toolkit and things that you can do to optimize your success. Thanks for being here. Hey there, I'm Sarah Clark, founder of Fab Fertile and your host. I believe the functional approach is the first step for anyone struggling with infertility, and my aim is to help you get pregnant naturally. Today, I'm welcoming Kristen Jones to the podcast, and we're digging into everything you wanted to ask an embryologist. And so Kristen is an embryologist with a master's degree in reproductive medicine, and she uses her Instagram page, I Like My Eggs Fertilized, to educate and guide people through their trying to conceive and IVF journeys. So thanks so much for listening. And I'm so thankful that you're here. Make sure you hit subscribe. And if you know someone else who is on the fertility journey, please share this podcast with them. Hey, Kristen, excited to have you on the podcast.
Hi, thanks so much for having me.
Awesome. Yeah. Can you share your journey about really how you came to do this work?
Okay, so out of high school, I didn't know what I wanted to do. So I did science because that seemed interesting to me. And my goal in doing that was actually to get into forensics because I'm obsessed with true crime stories and documentaries. So I really wanted to get into forensics. And unfortunately, where I am in Perth in Western Australia, it's very hard to get into that field. You have to go through the police force, and apparently it's quite difficult. So I did find out during my university degree that I could get into fertility, which I thought was amazing. So I jumped at that idea and did my internship at an IVF clinic. And I knew from that moment that that was my passion. But it wasn't until I went through my own struggles to conceive my kids that I really realized the toll that it can take on your whole entire life, and it can just take over everything. So that's when I became really passionate about helping people to actually go through fertility treatment and educating people on, what they can do to make it a little bit easier for them, or just helping them cope with the stress. So that's when I opened my Instagram page, was because I just realized how lucky I was to have my two kids, and I just became so passionate to help other people get that.
Okay, awesome. Yeah, amazing. I find most people that come to do this work, there's some sort of personal story typically.
Yes.
Okay, and so I've done many episodes on our next question I'm going to ask, but around optimizing egg and sperm health. It's like a massive topic. I've done mini series and deep dives, so I'm just going to ask you that question from your perspective. What can we do to optimize egg and sperm health?
Yeah, so from my perspective is I'm seeing people that are already been trying to get pregnant for a long time. So by this stage, they're already seeing the doctors, and they'd probably be under the guidance of their doctors. So for both, for males and females, to get our eggs and sperm as healthy as possible, it's a lot of it's about your lifestyle and following a healthy diet, nutrition, and maintaining a healthy body weight, because having a healthy BMI, definitely the studies do show that has a massive link to our fertility. We want to try and avoid toxins wherever possible, especially for the men with their sperm. If there's men that are working on mining sites in the heat, or if they're working with toxins such as paints and chemicals, there's chemicals in our everyday lives that we put on our skin, or plastic drink bottles, BPAs in our plasticware at home. We want to be avoiding those chemicals, and talking to our doctor to see if there's any supplements that they recommend. For example, some doctors may put their female patients on CoQ10 or DHEA or growth hormone. Not all doctors are going to do that, and that's not going to be necessary for all patients. But it's worth having that conversation with your doctor, because there may be things that they do recommend that may be able to help you. In terms of sperm health, so this is something that can change quite dramatically. And I have seen people come through for semen analyses and their results are quite poor, and they can come through a few months later and have better results. And I have seen that in men that have cut down on their smoking, their alcohol, they may have been on prescription medication that they have been able to stop. They've been able to lose a little bit of weight. And one thing that a lot of people don't know in regards to sperm health is that there's this thing called DNA fragmentation, where you've got a certain percentage of the sperm which have little breaks in their chains of DNA. So some men are going to have naturally higher levels of DNA fragmentation, and we want to bring that down. So how we can do that is by having the men be, once again, cutting down your alcohol, your smoking and your chemicals and all that, but also increasing the amount of ejaculation, because when the sperm are just left sitting there, that's when they are prone to all of their damage, because they're just sitting there waiting around. They're susceptible to those environmental damages. So when people are trying to conceive, I think a lot of people have this misconception that they're going to save it all up and they're not going to ejaculate for a week before because they need to build up that sperm count, whereas that's actually not good for the health of your sperm. You obviously don't want to be ejaculating too much, because the sperm count will drop. We do expect that, but in the lead up to either egg collection or in the lead up to ovulation, if you're having a natural cycle or an insemination, maybe just increase that ejaculation. If you're doing it every 3 to 4 days, maybe do it every 1 to 2 days, because that will keep the sperm a little bit fresher, a little bit healthier. And those are probably my top tips for egg and sperm health.
Okay, yeah, definitely the lifestyle side of things, and the toxins. We dive deeper too into like food sensitivities, gut infections, and yeah, the whole the environmental toxins one is a massive topic, right? With people, we having people switch out their personal care, their cleaning products, yes, the water that they're drinking, the EMF, so the magnetic frequency, kind of that exposure to your cell phone and Wi-Fi, all that can have a negative impact on both male and female fertility. And then also, even the air that you're breathing too, as you're saying, like if someone's, depending on what career they've chosen, if they're exposed to a lot of these different chemicals too. So the particulates in the air, we do hair tissue mineral analysis testing. We can see, heavy metals in there. And if they're eating, maybe too much larger fish with mercury, that can show. Even with the water they're drinking, if it's not filtered properly, it can show sort of uranium and different things from the rock, depending on where they live in the world. So it's quite fascinating as you dig into this. I think many times people think, oh, this is the diagnosis, this is what I have, this is the only thing I can do, and there's so many things you can do to shift the needle. So
many different layers. That's exactly right. So many things that you can look into.
Mm-hmm. And so let's dig into kind of more of what you're seeing here in the lab as an embryologist. So let's talk about your thoughts on frozen versus fresh cycle. And we'll talk about, so we've got questions on, is it better to do it on day 3 or day 5, the transfer? So I'll just talk a little bit about my own story for a minute. So I was diagnosed with premature ovarian insufficiency, and I had both my kids with donor eggs. And so this was like my daughter's going to be 20 in like 4 days, and my son's 17. So this is, many years ago. And back then they were only doing frozen cycles. They didn't do fresh cycles. So let's talk about the difference between that and kind of what you're seeing as sort of the best practice.
Yeah, so best practice, that's going to be, individual on a case-by-case basis. And I know that there are a lot of clinics that probably do majority frozen embryo transfers, and there's a lot of clinics that they're happy to do fresh where that's suitable. And I think, if a patient's not hyperstimulated, if she got, a small number of eggs, not a massive number of eggs, she's got a good number of eggs, she's not hyperstimulated, her progesterone hasn't gone up, her endometrium's looking good, then, the doctor may well be perfectly fine with them having a fresh fresh transfer, but there's going to be a lot of situations where a fresh transfer just isn't going to be possible. And that's where we've got your premature progesterone rises that are going to affect the endometrium, or there's a large number of eggs that are going to put the patient at risk of ovarian hyperstimulation. So yeah, absolutely, there's a place for both. There are a lot of clinics that they just believe that when a female has been put on those egg collection stimulation drugs, that the body's not in an ideal environment to have an embryo put back in. But I still see a lot of pregnancies from fresh transfers. So, I mean, if it was myself going through and the doctor said that, in my particular situation, they'd be happy for me to have a fresh transfer, absolutely. I'd want them to choose the best one and put it back in on a fresh transfer. But then again, on the other side, if the doctor said that their recommendation would be for me to have a freeze-all cycle and, come back for a transfer in a subsequent cycle, then I would be fine with that as well, because I know that the techniques that we have in the lab for our freezing and thawing of embryos is very, very good.
And what about the day 3, day 5 question? What's the best thing there that you're seeing?
Yeah, so that's a good question. So we do like to, and this is going to be individual based on different patients and different clinics as well. There's going to be a lot of clinics that will only do day 5, and I think it's great where there's clinics that offer both. So once again, we do like to go to day 5 where possible, because we get more information about those embryos. And when there's a lot of embryos to choose from, it's, we've got the advantage that we can grow them to day 5, because that will naturally deselect a lot of the embryos. They're not all going to make it to the day 5 stage. But the embryos that do make it to the day 5 stage, they have a good chance of pregnancy. Now, in those patients that aren't getting big egg numbers, or their embryo development isn't as good, then I still see a lot of pregnancies with day 3s. There's just some patients that we see that their embryos don't seem to do as well in the artificial environment of the lab. So I've seen, and there's even an Instagram page actually of a doctor. She's changed her handle now, so I can't think of what it is, but she went through multiple day 5 embryos, embryo transfers, and just did not get pregnant for years. And eventually she just said, look, please let me try a day 3. And she did, and she got pregnant straight away after years. And I absolutely see that in the lab, where there's some patients that may get a low egg number, only have a couple to choose from. So we choose the best one on day 3, and we still get lots of pregnancies from that.
Okay. So let's go into the criteria for freezing. What are you looking at?
Yeah, so we are only going to choose embryos that are suitable. So we want to know that an embryo is good enough quality that we think it has a good chance of pregnancy and a good chance of surviving the freezing process and the thawing process. So when we are looking for a day 3 embryo, if we're going to be freezing on day 3, for example, we want it to be in the correct cell range. We want it to be in our correct cell number range. Different labs may have slightly different guidelines for what that number is. And we want to have, live cells. We don't want to have degenerating embryos, and embryos that are not too fragmented. So we want those cells to be nice and even and healthy and looking good. So good quality embryos. They may be borderline, they may be a little bit poor, but the embryos that are quite, that are quite fragmented, quite poor embryos, we may not choose to freeze or want to freeze. When we're talking about day 5 blastocysts, we want to see, trophectoderm, which are those cells around the outside. We want to see nice plump layers of trophectoderm and a nice decent size inner cell mass that looks like it's got nice cells in it. Once again, those embryos that are looking quite degenerated, quite poor, we're not going to choose for freezing. Labs will have different guidelines of the expansion. So some labs will only freeze embryos that are fully expanded or hatching, whereas other labs are going to be happy to freeze those much earlier embryos. Or other labs may say, no, I'm not going to freeze those earlier embryos those earlier blastocysts, because I don't actually know whether they've got an inner cell mass or not.
Okay. And then, so the question on embryo grading, you hear a lot about this. So how does that work?
Yeah, so once again, that's different with day 3s and day 5s. When we're talking about day 3s, each lab, lots of labs will have a different code. They'll use different codes for different things. So for example, if I'm grading as a grade 1 is a really beautiful, perfect embryo, I would give a grade 1 to an embryo on day 3 that has perfectly even cells. Those cells look nice. They're not pitted. They're not grainy, and there's no fragmentation at all. for me to give an average embryo, so like a grade 2 embryo, the cells will be nice and even, but they may not be perfectly even. There may be a little bit of fragmentation present. And then those heavily fragmented embryos, heavily uneven embryos, will get a grade 3 or a grade 4. When we're talking about day 5s for our trophectoderm, a lot of labs will use an ABC, or a good, fair, or poor. And those good ones are going to be your nice, plump, juicy trophectoderm cells, lots of layers, and your inner cell mass is going to be nice and big, nice and plump. Whereas your more average embryos will be your fair or your B grade embryos, and then your C grade will be your very poor embryos. So they're very thin, they're very degraded, they may be quite patchy.
Mm-hmm. Okay. And so this next question is, we see this all the time with the PGS testing, so the pre-implantation genetic screening. Pros and cons of this.
So this is an interesting one, because I know that there's some countries around the world where they really encourage all of their patients, or most of their patients, to undergo genetic testing. Whereas in Australia, it's not like that. You have to fit certain criteria to go through that process, which I think is quite good, because there are risks involved that a lot of people don't realize. And, seeing what happens in the lab, definitely, I think a lot of patients wouldn't realize the risk that, and it is a small risk, but there is a risk of damage to the embryos undergoing that biopsy process. So I think it's good where it is reserved for cases where patients really need it, such as they need testing for genetic diseases, or they are an older patient, they've had lots of miscarriages, or they have had losses that the doctor has determined has been due to a genetic abnormality. So I think it's absolutely fantastic that it's available for those kinds of patients. I think it's worth taking those risks, that small risk that there may be a damage to the embryo, because then, we need to understand that that embryo being biopsied may affect its ability to survive the freezing process and the thawing process after that. But yeah, I think it's wonderful and where needed. I disagree with patients just straight up saying, yeah, test all my embryos, because a lot of patients aren't going to need it. If you're a first-time IVF patient that has a good prognosis, obviously, depending on your age, depending on your cause of infertility, most patients will get pregnant without having their embryos genetically tested. So yeah, for myself, I was given the option of going through, because I am a carrier of a genetic disease, and I was given the option of going through IVF with genetic testing. And I had the very long conversations with my husband, and we decided we didn't want to go through that, because I've seen a lot of patients go through IVF cycles that have ended up with either nothing to biopsy, nothing that's tested normal, or nothing that survived the thaw. And it's a lot. It's a big process to go through. However, I've seen lots of patients go through it after having many years of unsuccessful treatment and get pregnant with those tested embryos. So I think it's amazing, but I do think that it should be reserved for those patients that really need it, because keep in mind that you may not need to put your embryos through that.
So an older age, miscarriage, losses, those sorts of things to consider, but even then not. And if you're a carrier of a certain genetic disease, and then again, it's very personal.
Yeah, and also to know that there is a slight risk that something can be wrong with the results as well. So we do know of, there's embryos that are mosaic. So we may be taking off cells of the embryo that are testing as abnormal, whereas really the rest of the other cells in that embryo are normal, and that embryo is capable of making a healthy baby, whereas we're getting the result that says, sorry, that's an abnormal embryo, do not use that. Or we may see an embryo that's mosaic high level. So we get high level mosaics, low level mosaics. And from what we're seeing in the studies now, those low level mosaics, depending on what they're mosaic for, can be capable of making healthy babies. So yeah, important to know that there are risks with the results as well. Once again, low risk, but still important to know.
And what's the cost typically of doing the testing?
Oh, that's going to be different. I'm not entirely sure, but I believe if you're having a few embryos tested, it is going to add a few $1,000s onto your treatment, but that's going to be different at different clinics.
And when did they start doing this? It's only in the last 5 years, I feel, or has it been longer?
Oh, no. So day 3 testing of embryos has been done for many, many years, but it's more recent that we're doing blastocyst biopsy now.
Okay. Got it. Got it. And so, so a typical day in the life of an embryologist, what does that look like?
Okay, so we get in early in the morning and check the fertilization results from the day before. So we've done all our IVFs and ICSIs the day before. So we come in early, check for fertilization, and we will check for any embryos that will need to be transferred in the morning and transfer them to the transfer dish. We will get ready for our appointments. So that'll be the embryo transfer appointments and the egg collections. We'll put any men in the room that need to produce sperm samples for those egg collection patients. And then, like for example, this morning, I sat down for a few hours, did some egg collections, and then I did some embryo transfers. And then after we have a little break, we come in and do our embryo freezing. So we'll go through and have a look through each patient and see what is suitable for freezing, get all that prepared, get those frozen, get them put in the freezer, and then get ready for our afternoon insemination. So for people that are having IVF, the sperm gets washed and put in with the eggs. And then for people that are having ICSI, we strip the eggs, get set up for our ICSI. So we set up our needles, we make our dish, and we pop our eggs and our sperm in that dish and perform the ICSI. So that I spent a few hours doing that this afternoon. And in between all that, we need to get ready for the next day. So we're preparing all of our files, we're preparing our dishes, putting our culture media in the dishes and getting them in the incubator prepared for the next day.
And so, obviously with this is like an extreme attention to detail and potential stress. Like how I don't know, how do you cope with sort of, this is like someone's future, you're kind of in your hands and stuff like that. So how do you cope with that? How do you stay calm?
Yeah, it can be quite a stressful job. And, we've all had days where we've kind of gotten more stressed than others. What is good with my job, which I think is great, is that and I don't know if all labs operate like this. I kind of assume a lot of labs will operate like this, but I don't have to kind of do the same thing every single day over and over. So I'll have a day in the lab, I'll have a day where I'm in charge in the lab, or I'll have a day where I'm helping in the lab. I'll have a day where I'll go do the sperm samples. I'll have a day where I'm in the office doing data entry. I'll have a day where I'm doing all my sperm donation things because I manage sperm donors as well. And so we get to do lots of different things. So they may need, if I'm a helper for the day, they may need help in the sperm lab. They may need help for me to do some thaws in embryology. They may need help to put some men in the men's rooms. So it's not actually, because if we were in embryology every day, it does get quite taxing, because it literally is a job where we can't make a mistake. We are cross-checking patient codes, patient dates of birth, patient numbers. We're cross-checking everything constantly. We're moving things from one dish to the next. And, we're constantly, getting verification, getting witnesses, scanning barcodes. So yeah, it can be stressful. And there are definitely some days where it's more stressful than others. Most of the time, it is pretty cool. And the patient contact is really good. We love talking to patients and updating them and talking them through what's happening. And yeah, there are definitely other days where it's a lot more stressful and we do have to give bad news.
Yeah, and as part of our program, we're helping couples with low AMH and high FSH and diminished ovarian reserve and premature ovarian insufficiency. So, what are you seeing on that angle for client or patients with those diagnoses?
Yeah, so with those diagnoses, of what we expect to see is they're the patients that are getting a much lower egg number. Doesn't necessarily mean they're going to get no eggs, but we do expect them to be getting a lower stimulation, a lower response to the drugs, and subsequently a lower egg number. That does not necessarily mean that they're not going to have success, because I've seen many patients get success with low egg numbers. And but yeah, they are the ones that we would expect to see lower egg numbers. They may not get as good embryo development, but once again, like I said, that doesn't mean they're not going to have success.
Mm-hmm. Absolutely. That's why the diet and lifestyle stuff is key to either get pregnant naturally or improve the chances of success. And so as far as on your Instagram page, like what do you have as for some frequently asked questions that you're kind of feeling? What are anything that I've missed here from what you're getting asked, I guess?
Yeah, so the day 3 and the day 5, and the fresh versus frozen. The other one would be IVF versus ICSI. A lot of people ask me, is ICSI better?
Right.
And I say, no, not necessarily. That's going to be completely individual to each patient. And if ICSI is warranted, such as you've had a history of previous poor fertilization, or your partner has a very low sperm count, then yes, absolutely, you're going to want to do ICSI. However, if you've had natural pregnancy before, if you've had previous good fertilization, or if it's your first cycle and your partner has good quality sperm, there's no reason to be jumping straight to ICSI. Absolutely, there's going to be patients that unfortunately they do normal IVF and they won't get fertilization, and they'll have to come back and have a cycle with ICSI. You know, I won't lie and say that doesn't happen, because that does happen in a very small percentage of cases. But you know, if it was me and my eggs, I would absolutely, if IVF was possible, do IVF, and then if the doctor said no, we need to do ICSI, then I'd go and do ICSI.
Mm-hmm. And then, and so what are some resources that you like to refer people to? A book, a website, an app, a documentary, anything that you can just be personally obsessed with? And then I think you have a book you wanted to recommend too, but anything that you're
Oh, yeah. So the book that I recommend for people that are just starting out with their, if they're just starting to kind of prepare themselves for trying to conceive, is the Taking Charge of Your Fertility book by Tony Weschler. So that was one that I loved when I was getting prepared myself. And I found that very helpful and very informative. And I think I learned just as much from that book as I did from when I did my master's in reproductive medicine, because it really takes you right through your own menstrual health and reproductive health. So I found that quite helpful. In terms of other resources, I love the website In Vitro, because I think they have a really good way of explaining things, and their infographics are great. And that's if you're going through fertility treatment. And yeah, the reason I started my page was because I just found there wasn't a lot out there for people going through fertility treatment. So that's why I wanted to kind of break it down into little topics. So yeah, I've also got my Instagram page.
Awesome. Yeah. And so, yes, your Instagram page is I Like My Eggs Fertilized. So definitely check that out. And is there a success story? I mean, there's lots that you're probably seeing. What's the success story you want to share with us?
Oh yes, yeah. So there's definitely been a lot of amazing ones over the years. The one that sticks out in my head was, I remember talking to a patient after her egg collection, and she was just absolutely devastated that she'd only gotten one egg, and she couldn't believe that she only got one egg, because I think she was expecting that she'd get quite a few more. And she was saying to me, what do I do? What do I do? I don't know, going forward, do I have to have another cycle? What do I do? And I remember saying to her, you need to have the discussion with your doctor. And I'm sure there are other things that your doctor can try, but for this cycle, you've got one egg. So you still need to see what this one egg does, because this doesn't mean your cycle's failed, because you've still got an egg. So it still might fertilize, and it still might make an embryo, and it still might make a baby. And absolutely, for her it did, and she got a baby from that one egg. And I remember her being so upset after that egg collection, crying, because she just didn't know what to do, and she didn't have to do anything. And I find a very common point of disappointment for many people. I mean, there's many steps along the way, whether it be poor fertilization or poor egg numbers or poor embryo development, that they just get very, they get in this despair that they don't know what to do, and they don't know why this has happened, when really, if they've got embryos there, there's still chances that they have, and they need to utilize those chances before getting too caught up in what they need to be doing next, because those chances that are sitting there waiting, they could very well be a baby that's about to happen for them.
Yeah, that hope and belief. I've just got as we're recording this right now, we've got a series on faith and fertility coming up, all different faiths, and also the universal kind of like trusting your intuition. So it's interesting, because it's typically, I find it's like these typical like type A driving, like professional women, blah, 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 blah. And then, you look at that and go, wait, I want a whole bunch. Meanwhile, the one was the one that does it. And it's it could be devastating, right? When you get that, but for her, it was the one, and it can be the one.
It can be. Absolutely. It can. Yeah. And also keep in mind, some people get absolutely zero. So one's better than none.
Mm-hmm, mm-hmm. So any final thoughts on our topic today?
No, oh, what I will say is just don't hesitate to reach out for help and support if you are in those early stages, or if you're starting to, if you haven't even started yet, or if you're starting and you're struggling, always reach out for support, because there's so many different forms of support out there, and you don't need to do this alone.
Awesome. Great. Well, thank you for all the work that you're doing, and thanks for sharing your words of wisdom. I appreciate it.